Pelvic Health Podcast. I'm Susan Winograd, the owner and founder of Pelvicore Rehab, and I am thrilled to be your host today. Thank you so much for joining me. We have today on your Pelvic Health Podcast the icon, the rock star of physical therapy. In my mind, she is like the Madonna, the Bon Jovi, the Elton John in the physical therapy world. Carolyn, don't be so modest. I'm going to read, I do not read everybody's bio, but I am going to read Carolyn's bio because I really want our listeners to understand the guest that we have on today. So I'm going to read Carolyn Vandyken's. She's a physio out of Canada, and I would like to share this with everybody. So Carolyn Vandyken is a registered physiotherapist, pelvic health educator, researcher, author, and co-owner of Physio Muskoka. Carolyn is one of the co-owners of Reframe Rehab, a Canadian-based international teaching company with a mandate to educate healthcare professionals about integrating a biopsychosocial approach to healthcare. With 34 years of clinical practice, Carolyn has contributed chapters to 3 international textbooks on pelvic pain and the overactive pelvic floor. She has co-authored a patient-centered book called Why Pelvic Pain Hurts, and has co-authored 5 research papers on pelvic pain, low back pain, and incontinence in peer-reviewed journals. Carolyn speaks extensively at international conferences on the topic of pelvic health and a biopsychosocial framework. Carolyn received the YWCA Women of Distinction Award in 2004 and the Distinguished Education Award from Ontario Physiotherapy Association in 2015. Carolyn was recently awarded the Medal of Distinction from the Canadian Physiotherapy Association in 2021 for her work in the pelvic health and pain science. Wow. What a bio and what a career. I have told many people that when I graduate, I want to be like Carolyn. When I retire, I want to be like Carolyn Vandyken. I've told so many people that. So Carolyn, welcome.
Well, Susan, my goodness, I don't know that I've ever had such an introduction. So thank you for that. That's very kind.
Well,
and I'm happy to be here.
Thank you. You completely changed my practice, Carolyn.
Fantastic.
Do you remember when I was, reading our notes, the prep doc, I was like, how did we actually connect and meet? I think that I had heard your name and I was kind of looking at your website. Tell me if I'm wrong. And I had a very complex client that I did not know what to do with. We just were not making any gains. And I think I recommended that I do a Zoom and a co-visit with you with that client. Am I right?
I think you're absolutely right, Susan. That's exactly how we met. I was thinking as you were asking the question, how did we meet? And then as soon as you started talking, I'm like, yes, you reached out. And to me, that's the epitome of a fantastic clinician, someone who goes above and beyond and really thinks about how can I best meet this client's need in front of me. And you were stuck and you're like, okay, there's more answers out there. And he was a tough one. I remember that very clearly. That was a difficult situation.
Yes. So. And after that visit, I really jumped on the Carolyn Vandyken bandwagon, meaning I just started taking your courses. I joined Embodia, and right now I'm taking one of your courses for the second time, and I plan to take all of them a second, a third, and a fourth time, because every time you listen, you realize that you missed some stuff the last time. Carolyn, can you tell us a little bit about what inspired you to really recognize that our field and our profession needed change? And how did that lead you on the biopsychosocial path? And then, I definitely would like to discuss the state of physical therapy and what needs to change. But I'd love to hear what inspired you to really make this your passion.
So great question, Susan. And I think it's a myriad of experiences, isn't it? It's never just kind of one thing. But for me, I had practiced in orthopedics for about 15, 18 years when I moved into the pelvic health world. And like many pelvic health physios, at least, sort of 20 years ago, I moved very much into that world because of my own issues with pelvic health, having had 3 large babies and lots of complications with that. So that sort of started my journey. And I got real curious. When I took my first pelvic health course, I realized, I was so disconnected to my pelvic floor, and I'm a kinesthetic learner. I'm an athlete. I've always been active and fit, and I was so disconnected to my pelvic floor. And so I walked away from that first course thinking, well, if I'm disconnected, how many of my patients are disconnected from their pelvic floors? And so that started that journey. And I had some great mentors along the way, and I really want to give them credit. Marie-Josée Lord, who is a fantastic pelvic floor physiotherapist here in Canada, was my sort of initial instructor and mentor, and she taught me a lot about pelvic health. But, back then, 22 years ago, we strengthened the pelvic floor. That's what we did. Everyone got strengthening exercises.
That's what we learned in school.
Right. It was all about Kegels, right?
Yeah.
And so, that was about it was early 2000s that my pelvic health career started. I graduated in 1987. And then it was sort of 2005, 2006, where I took a course with Rhonda Caterina from Chicago. And she was really the first one to start talking about the short, tight pelvic floor and how, these muscles weren't just weak, they were actually tight as well. And that really struck a chord with me. And so I was very grateful for that course. And that was sort of 2005, 2006. And then probably the biggest game changer for me was taking a course with Debbie Patterson, who I would also have to say and give some recognition to, that she has been a great mentor for me. And she'll say we mentor each other, and I think we do at this point, which is great. But she's a 40-plus year physio here in Canada who has really been taking a biopsychosocial approach, I would say, her entire career.
Wow.
And I took a course in 2008 called Women in Pain. And that was the first time that I really had heard about the sensitive nervous system, central pain mechanisms, and what was changing in the nervous system with pain. And wow, she just opened my eyes, and I could see my patients that I was struggling with, and recognized that I was missing a big piece of the puzzle. So from there, I went on in 2010 to attend in the UK the first World Conference on Neurodynamics and the Neuromatrix, which was put on by David Butler and Lorimer Moseley. And that, of course, blew my socks off. And from that point on, I really started to dig deep into pain science and understand the pain system and pain at a deeper level. But the funny thing about that conference was it was really geared at musculoskeletal therapists, right? Sort of MSK physios. And there was a couple of us, probably a handful of us, that were more identified, I would say, at that point as treating pelvic health as their dominant area of practice. And Sandy Hilton was one of those. And I had a very chance meeting with Sandy Hilton on the bus on the way to the conference. And I did everything that your mother tells you not to do. I eavesdropped on one of her conversations because I was really curious as she was talking to one of her colleagues about pelvic health. And how does this relate to pelvic health? And so I introduced myself and we chatted for a few minutes. And then at the break on the second day, we went up to David Butler and we said, this information around graded motor imagery and pain science education is really interesting. But we're pelvic health physios, and you're talking a lot about laterality and mirror work and all those sorts of things. And how does that really apply to the pelvic floor, which is a central structure with left-right discrimination? And he just looked at us and said, hell if I know, go figure it out. That was his words. So Sandy and I did that. We started a relationship, which has been fantastic. And her and I dug into the research, dug into the literature, and started writing about it and playing with things in our clinical practice. So that was 2010. And really our practice, I think, was a bit sort of free evidence at that point. We were trying to apply what the MSK therapists were doing to pelvic health. And as we continued to grow and develop in this area, we're starting to realize that, we got it not bad from a correct perspective back in 2010, 2011. Like, I think we kind of nailed the essence of kind of this approach and why this is so important in pelvic health. So that's kind of my journey into where I am today.
So basically you're saying that you're a result of eavesdropping landed you a conversation with David Butler, who is like literally the last word in pain science. So you are telling me that I should start eavesdropping on public transportation?
You know what? In the right setting, that could be a very helpful thing. Forget what our mothers say and just say, there are times when eavesdropping really kind of moves you forward in the world, right? I was very thankful.
Carolyn, you know me. I'll talk to anyone who's willing to talk to me. So I am down for that. That's amazing. So how did you actually start integrating it? So, and can we just, for our listeners, because this podcast is for clinicians, but it's also to educate people that want to know more, that are seeking help. Perhaps they're in the beginning of their journey, or perhaps they're frustrated by a journey that's been taking too long. Can you kind of define what taking a biopsychosocial approach to healing means? I tell my clients all the time, but I would love to hear how eloquently you're going to describe it.
So a biopsychosocial approach kind of asks us to think about the person in front of us as a whole person, right? Which really is embodied by the definition of pain. And let's face it, most of our patients are seeking our help either for pain or incontinence, some sort of functional issue, and I'm talking pelvic health. So maybe if you're an MSK therapist, they're seeking your help because they're having trouble with running, or they're having trouble with some functional task. For us, it's incontinence. That's the functional task. And pain, right? And if we look at the definition of pain, it's right there. And yet most of us who treat pain don't look at that definition and say, I need to treat the person in front of me. So the definition of pain is an unpleasant sensory and emotional experience. And that should really hit home, right? Pain is not sensory or emotional, it's sensory and emotional. And it is produced when our tissues are injured. So we understand that piece. But it's also produced when our tissues are starting to approach the edge of tissue tolerance, or starting to approach the potential for injury. So that's really where persistent pain comes in, because we can have all kinds of pain and not have any tissue involvement, any tissue injury, but our brain is worried that we're getting too close to the edge of our tissue tolerance and it's going to shut us down, right? The problem, though, with pain is, and that's the last part of the definition, it's always described in terms of damage to the body. And so what we have historically been trained to do is to look for that damage, to look for the injury, to look for the tissue problem. But what we know in persistent pain is that tissues heal, full stop, in 12 to 16 weeks. And I'm being generous there. In 16 weeks, all tissues have healed. If you've had an injury and it's been more than 4 months, your tissues are healed. But then, and this comes from Sandy Hilton, and I really like how she says this. She says, beyond that, if you're still having pain, and we call that persistent pain, not chronic pain, that's because your tissues are tight, your tissues are weak, or your system has become more sensitive and overprotective. And it's that sensitive or overprotective piece that we as a profession have not spent enough time really understanding and really developing solid sort of assessment and treatment tools for. So when you take a biopsychosocial approach, that means if you're a patient, you should be looking for a clinician who asks you about your emotional distress, who asks you about your thoughts and your beliefs and how you're struggling kind of moving through the world with mood, for example, and other sorts of pieces, and not just asks you about them, but actually uses tools to measure that piece. Because again, we can't see into someone's psyche, into someone's emotional wellness, and we're not trained as physiotherapists. I mean, psychologists are highly trained in that piece. We're not. And so we need to use questionnaires to assess that emotional component of the pain experience. And once we do that, it opens up an opportunity to treat pain from a whole person perspective.
I love that. I don't know about you, Carolyn. I have so many clients that come into my office and we do treat complex pain, and they come in with binders, literally with binders color coded with sections of all the tests they have done, and they're all negative, and they start to believe that they've been told that they're crazy. It's all in their head, but no one has ever told them that it is possible that they have pain in the absence of tissue injury, or that their tissues have healed. And I think it's so, I wish that all healthcare providers would really validate their clients' pain, but also stop sending them down this rabbit hole of one test after another. I don't know how many clients you've had that have had so many tests done. In the end, somebody told them that their herniated discs were the root cause of their problem. And then we have to, sort of educate them that 70% of the population, it is possible, but that also 70% of the population have discs that are herniated to some degree, and they're completely asymptomatic. But once you find out that you have a herniated disc, all of a sudden, that becomes the problem or the root cause. And I wish that we could, and we are doing that, I believe. And that's why I wanted to have you on today, that if someone feels pain and they feel like there is no hope or no answers, there is. Our bodies want to heal. We need to find a provider that really uses a biopsychosocial approach, because if nobody could find anything that's wrong with the tissues, then we need to change what we're doing, which leads us to what you think the state of physical therapy is today.
Well, it's interesting. That's a great question and great observation, Susan. And I would say I struggle with the same thing, although I almost have an equal experience of patients who come with a test that was done, I always say, as a fishing expedition, right? So tests should not be done. To me, an MRI should never be done to see what's wrong. An MRI should confirm what you found on a good clinical exam.
That's brilliant.
So if you found the signs and symptoms of an L5-S1 disc herniation, and they follow dermatomal and myotomal patterns, and there's an S1 reflex loss, and you've done in Canada, because we don't get MRIs so quickly here, in Canada, you've done, that takes 2 or 3 months to start to see some good results with treatment, an active treatment approach, and they're not getting better, and maybe now they're a surgical candidate. That is a reason to do an MRI. To confirm, because an MRI is a surgeon's roadmap. That's what an MRI is. It is not a fishing expedition.
Yeah. And I think I could totally be wrong, but my perception from the patients that I see is that it's not so much a confirmation here. It's like you're complaining about something or no one can figure it out. Let's do an MRI and see if we see anything. And my husband's an emergency room physician. He's so opposed to that. And he always says, if you look, you'll find something.
Yeah. Great. Brilliant.
If you look, you find. And sometimes we don't need to do all of those expensive tests to find something, because chances are it probably will exacerbate what we're already going through.
Right. There's a great study in 2001 that showed very clearly when patients were given their pathoanatomical findings from an imaging study, their outcomes were worse.
Yeah, it totally makes sense.
And so we have to stop imaging things that don't need imaging. And so your husband knows this better than anyone. We need to make a judicious use of when is an MRI needed. And because we're going to see things, it's like taking a magnifying glass and looking closely at the wrinkles on my skin and going, you have wrinkles. Well, I don't need a magnifying glass to tell me that, right? If I'm almost 60, of course I've got wrinkles. And so
I don't see any.
Yeah, I know it's the camera. Great. Thank you, Susan. But the issue is that when we look for something, we're going to find wrinkles on the spine. We're going to find gray hair and normal wear and tear changes. But the problem, the state of our medical system in the Western world now is that, and a lot of it was because of Rene Descartes way back a couple hundred years ago, who kind of separated body and mind, right? And said, the church will have the mind and the spirit, and the medicine will have the body. And it doesn't work that way. People don't work that way. We are one complete sort of person, right?
Yeah.
And our emotions, we have great evidence that our emotions can create distress and pain for us, right? We don't have to have a tissue problem in order to have pain, but that doesn't mean it's in your head. That just means your whole system is out of balance. And there's an emotional driver to that piece of being out of balance. And if we all really think about our life, maybe as a child even, where, we woke up with a tummy ache one day, and our wise mothers would say, what did you eat? Do you need to vomit? What's going on? So they check the tissue piece, and then they say, what's going on at school today? What else is going on? And so somehow we remember that with a tummy ache when we're kids, and we forget as adults that when we're distressed about something in our body hurts. We get a headache. We get a tummy ache. Old pains, old injuries that have healed start to become more sensitive again. And we've got good evidence to support that. Right. And yet we continually forget that piece.
Yeah. And there's a reason why when our patients are doing well, and even when we've implemented or used a biopsychosocial approach, when the stress in their life skyrockets, that is, in my experience, the number one reason why they may have a flare or their pain comes up again. And once clients come to us, they're able to recognize that, and they have the tools in their toolbox to be more resilient with that and modulate that so much better. I wish that, we could get the message out there that your emotions, stress, depression, anxiety, worry, all affect the pain that you're feeling in your body.
Yeah.
What are
Susan, our patients know that, right? I start from a biopsychosocial framework by sending my patients, even before they come to see me, a suite of questionnaires to answer. And so my patients come kind of primed and pumped to think about their emotions and their whole system and what's going on. And sometimes they say, wow, that was a lot of paperwork. And it is. It's about 20 minutes worth. So again, not horrendous, but, a bit of a commitment. But then when we start right from the beginning talking about pain as a more complex experience, they get it. Like they will say very quickly, oh yeah, I have a sensitive nervous system. I know that. Or, oh yeah, I can tell when I'm stressed, my pain is worse. So when we really give them the opportunity to talk in that language and validate it, they get it. We don't have to convince them that this is a connection. Right?
I actually have never, I was a little hesitant. I remember when I took your first biopsychosocial course, and it was all about implementing these questionnaires, which I've implemented even more since then. And I was a little worried. I thought to myself, well, my intake form is already pretty extensive because we really, at Pelvicore Rehab, we prepare for our visits. We want to make it as efficient as possible. I said, well, now I'm going to implement 5 more questionnaires or 6 more questionnaires. What are my clients going to think? Or are they going to be annoyed? And I have to tell you, every single one, I believe, have found them so incredibly validating. Many of them come in and say, no one's ever asked me about that. No one's ever asked me how I'm feeling. Do I feel down? Do I feel stressed? Do I worry? And I think that if any PT is on the fence about implementing so many questionnaires, you will be letting your client know before they even come into your office that you care about them as a whole person, that you are going to be that clinician that's going to make eye contact and want to hear their story and want to really connect all of the pieces of that pain puzzle so they could heal for good. I want to just touch on the questionnaires for a second, because we always, in your courses, you say a lot that as physios, in Canada, we call them physios. In America, they're physical therapists. We before I met you, I really did pride myself on the fact that I treated the whole person. My tagline to my business is Pelvicore Rehab, a total body approach to treatment. So I thought I was doing the right thing, and I thought that I was down training the nervous system, and I thought that I was helping clients find ways to modulate that, but I was, kind of poking in the dark. Now,
Mm-hmm.
since I met you, we really look at, well, what part of their nervous system is being affected, right? And then we what emotions is it that's causing them to be in more pain? Is it depression? Is it anxiety? Is it stress? Is it worry? Is it that they feel dependent on somebody else to implement their care and they don't feel like they can be empowered to take care of themselves? Or is the connection and the communication between their brain or their nervous system and their body, not giving or receiving the proper signals? And I think it's also so empowering once you look at the questionnaires and you look at the client's self-reported answers to let them know that we're going to incorporate a strategy in your plan of care based on what you as an individual have reported that you're feeling. So I think that's incredible. And I think that you're really a pioneer in the field for kind of bringing that to the table for everybody, because I know how passionate you are about teaching and researching. Carolyn, I think that a lot of our listeners may not understand when we say that a client has a sensitive central nervous system. Could you touch upon that a bit?
Sure. So again, when we're listening to the history, and you're so right, Susan, in that when we set up that initial contact with the patient in a really careful and constructed way so that patients come in knowing that we're interested in them as a person, that we sit and listen, we put down our pens, we're not typing on the computer, we make eye contact, we really validate their story, whatever it is. And, that's what builds therapeutic alliance, right? And we know that therapeutic alliance is responsible for about 30% of the outcome.
Yes.
It's huge. It's one of the strongest predictors of if you're going to do well with that patient. So first of all, setting yourself up really well for that piece is really, really important, right?
Agreed.
And then as you move forward, looking at the indicators for sensitivity and the correct term that we should be using now, according to the International Association for the Study of Pain, is nociplastic pain. And that's a relatively new sort of pain category. We have nociceptive pain, which is changes in the tissues, creating nociception or danger signals that creates a pain response in the brain. And in nociceptive pain, you see a very logical, reproducible, tissue-based story. They had an injury or they had a repeated load kind of event, and they sensitized or injured some tissues, and they respond very mechanically, right? There's a mechanical sensitivity going on. And so that's nociceptive pain. Neuropathic pain is when there's actually been some sort of lesion or injury to the nervous system itself, and you, again, like this L5-S1 disc herniation that has changes in the sensory and muscle functions of the S1 nerve root, and fits that pattern of leg dominant pain, you can say, okay, there's been some injury to the nervous system. That's neuropathic pain. And then central pain mechanisms, or nociplastic pain, is where the nervous system itself has adapted or changed and has become more protective. So there's physiological changes. This is not, be really clear with your own sort of clinical reasoning and for your patients that this is not in their head. They're not just thinking about this wrong. Their nervous system has physiologically changed to become more protective.
Yeah, their
right?
pain is
and
real.
So 100%, all the time. Your pain is always what you say it is. none of us as clinicians should ever question our patients or roll our eyes and say, oh, they're exaggerating. They're not exaggerating. That's their pain experience, and we need to validate their pain experience. And the new definition of pain, which was just republished in 2020, and I gave you kind of the core of it a few minutes ago, but what I really like about the 2020 definition is they added some pain notes. And the first pain note is that all pain is real. End of story. All pain must be looked at from a biopsychosocial perspective.
Correct.
That's what the international body for the study of pain says we all must do. And yet that's been such a difficult journey for us because we are so focused on the bio piece that the psychological and the social pieces, which are just as important, if not more, in persistent pain, are ignored, right? So as we're listening to the history, we're looking for nociplastic pain. And Keith Smart did a really nice study in about 2010. It was an eValcy study. And what he showed was that if your patient in front of you is presenting with allodynia, which means light touch causes pain. So, these are our pelvic pain patients that can't stand to wear underwear, right? Or anytime they sit on a chair, that even light pressure will cause pain. So allodynia or hypersensitivity. So that's where you're starting to manipulate the tissues. And instead of just feeling pressure at, when you're doing some skin rolling, looking at connective tissue, or if you're doing more of a deeper pressure assessment of the muscle, if that's hypersensitive, we used to call them trigger points. We need to move away from that terminology. That's probably another discussion for another day.
Yes.
But when they have allodynia and hypersensitivity, there's a 30-to-1 odds ratio that nociplastic pain is driving that pain experience, right?
Correct.
And so if you remember your odds ratios, 1-to-1 is considered statistically significant. So 30-to-1 is huge, right? Like if you see or hear allodynia and you're assessing them and they're hypersensitive to touch, you can be very certain that nociplastic pain is driving that scenario.
Absolutely.
So that's one. The second is how long have they had their pain? If it's been longer than 12 to 16 weeks, there was a 27-to-1 odds ratio that nociplastic pain was the driver. If they have diffuse pain, so if their pain is spreading, from shoulder to elbow or right shoulder to left shoulder, that's called diffuse pain, and that's a 15-to-1 odds ratio. And then if they have some sort of cognitive thought structures like fear and catastrophization, and all catastrophization means this is the worst thing that could happen. I'm not sure I can cope with it, right? If that's sort of underlying or underpinning their experience, then there's a 7-to-1 odds ratio that nociplastic pain is driving their pain experience. So you're listening for those things. And then you can also use tools like the Central Sensitivity Inventory, which is connected with more the psychological comorbidities of nociplastic pain. So if they have any of the comorbidities on Part B of the CSI, so those are things like fibromyalgia, migraine headaches, TMJ, whiplash-associated disorder, IBS, depression, anxiety. So the list of 10 conditions. And just so you know, if you're a pelvic health clinician, every pelvic pain diagnosis, pretty much, every is a strong word, but probably 95% of pelvic pain diagnoses are connected in research to central pain mechanisms, right?
I think that's so profound.
Yeah. So you're looking for comorbidities, you're looking for sort of other conditions that they have, or on Part A, you're looking for a score greater than 40 on the Central Sensitization Inventory or Central Sensitivity Inventory. And if they have a score greater than 40, again, you're starting to think there are significant psychosocial comorbidities here that are sensitizing their system. So it's about using a bit of a structured approach. Yeah. And then once you identify that nociplastic pain is part of their story, you really need to profile their nervous system. And that's where the questionnaires come in. The questionnaires give us the ability to phenotype or profile the person in front of us. And, as you said, is it depression? Is it anxiety? Is it stress? Is it catastrophization? Do they have low self-efficacy, highly predictive of sensitization? Do they have low positive affect? Is there injustice? Is there fear, right? Is there shame? We see a lot of that in pelvic health. Yeah. Or is there sensory motor changes, sensory motor dysregulation? So those are the 10 pieces that I look at consistently. There are other factors for sure, But those are pieces that, as a physiotherapist, I can intervene with, as well as in an interdisciplinary team. So you don't have to go it alone, but you certainly have to start thinking about these broad constructs.
Right. And for people that are listening out there that are mental health professionals, I think it's also really important to articulate that we treat depression, anxiety, stress, worry, catastrophization, self-efficacy within the scope of our practice. Mm-hmm. So just for example, Carolyn, if someone's self-reported scores are high on depression, we will integrate into their plan of care some kind of cardiovascular component, right? Because cardiovascular exercise has been shown to decrease depression. However, we want to be clear that we recognize that collaboration with other healthcare providers is essential, and we refer to psychotherapy all the time. I'm always very happy when a client asks for a referral, because there are a few therapists here that I refer to that also really take a whole body approach. So it's not only talking therapy. So I feel grateful that I've connected with those kind of therapists, but that we're not treating the depression, the anxiety, the stress. We're treating it within the scope of our practice to decrease their pain.
Mm-hmm. There's a great study in 2011. I know Paul Stratford, he was not the lead author from MAC. Can't think of the lead author right now, but it followed 692 low back pain patients in physiotherapy practice. And what they showed very clearly, this was a prospective study, is that actually their psychosocial distress scores predicted who was going to do well and who wasn't going to do well. And when you actually remeasured those distress scores at midterm and at discharge, if their psychosocial distress wasn't changing, they were going to have a poor outcome from a pain and a function perspective, right? And sense. So it's not, we indirectly address the depression through exercise, through some cognitive strategies that we can do. And the other reason I love to use screening tools like the depression, anxiety, stress scale is because if they're in the severe self-reported category, the extremely severe, I now have some ammunition in my hands to say to my patient, listen, this looks like you're really struggling with this. Like, you're self-reporting in a really high level of depression. First of all, I'm going to check in about suicidal ideation, right? I'm going to start to check in about what's going on with thoughts of self-harm. But it then allows me to have some objective measures around, you would really benefit from connecting with a therapist. Can we connect someone for you, with you, and can we all work together on this so that as their mood improves, right, and their depression decreases, and their mobility increases, they're doing cardiovascular exercise, maybe they started a yoga program, which is also helpful for depression, their sensitivity is going to decrease, and their pain is going to decrease, and their mood is going to improve. All those things happen together.
Right. And I think just from a more simple, basic perspective, when we implement the questionnaires and phenotype their pain, then we have objective information to retest. Mm-hmm. And it's so exciting for a client to be, to fill those questionnaires out again 6 weeks later and actually see that their scores have improved on their self-reported questionnaires. Because when we're living in our own body, sometimes it's nice, we want everybody feeling better, but it's sometimes hard to gauge how much progress you're making, and it's almost like catapults their improvement when they're like, oh wow, I really did better on that. Wow, I really am doing better. So that can, in and of itself, I think, take away worry, take away a bit of anxiety. So that's what I have found in my practice. Carolyn, one thing, when I began this journey with you in my own practice, I think I was very much like other therapists that viewed implementing a biopsychosocial approach was really the way out of persistent pain. What was eye-opening to me was that overactive bladder and bladder urgency is a centrally driven issue that people deal with. And, people that have urgency and people that have overactive bladder have a sensitive central nervous system. Can you speak to that a little bit? Because I want our clients to understand that if they're having bladder urgency and frequency, it's not just about urge suppression strategies or eliminating bladder irritants.
Right. So great question. And one of the things we now recognize is that urge is an output of the brain, right? We get danger signals from the bladder. Hey, I'm starting to get full, but how that's interpreted, how that's processed, and then what the output of that looks like is actually brain centric. Your central nervous system determines that, and it's all reflexively controlled. So your brain does a bit of a backroom calculation and kind of looks at what is my mood right now, where am I, how much have I had to drink, and we all know that intuitively, right?
Yes.
For any of you who've gotten up and spoken in public, know that what happens when you go to speak in public, all of a sudden, I have to pee, right? Or worse yet, I have to have a bowel movement, because your autonomic, your visceral tissues are very responsive to stress. So we kind of know that at a gut level. There was a great paper by Reynolds et al. In 2016, and the title of the paper is "Does Central Sensitization Help Explain Idiopathic Overactive Bladder?" And they go through all the research and all the evidence to say that actually we have a lot of evidence to support that concept. And when we think about urge as an output and as a centrally driven kind of sensitivity piece, it gives us many more opportunities to address the urge, right? Yes. To actually to fix, if you will, to normalize their bladder function. Right. And I would say, give me an urge patient any day of the week, and I can say that with confidence, 99% of them will get better very quickly if we take a whole person approach look at their sensitivity. Yeah,
I cannot agree more. And we learn that bladder function is a reflex. It's the micturition reflex, and the bladder itself is smooth muscle. We do not have voluntary contraction over our bladder. We only have voluntary contraction over our pelvic floor muscles. So to only treat the pelvis or the pelvic floor in bladder urgency and frequency and not treat the reflexive part or the sensitive central nervous system really doesn't make sense. But I think that clients don't realize that. I think a lot of physios don't realize that. And I think it's really important to put out there. I remember when I was taking a course with Susan Clinton, I think this was before I had even started taking my courses with you. And she was talking about the gut. She is, the gut master, the GI master. And she was saying that clients with a sensitive nervous system can have hypersensitivity or allodynia of the gut. So they may have the perception that they're more bloated or distended when they actually have normal levels of bloated and distension. They are just centrally sensitized. That blew my mind. And then when I met you in the part B of the CSI had IBS in it, I was like, it makes so much sense. So even taking a biopsychosocial approach for everybody with gut issues, or if they, are appropriate, we can help so many more people. Carolyn, what would you say to practitioners? Can you direct them as to where to go if they wanted to learn more about integrating a biopsychosocial approach into their practice? And what would you say to the people out there that are in pain, have bladder urgency, have IBS, and perhaps are looking for a physio, or perhaps are working with a physio and are not getting better?
Right. Okay. So, if we had to look sort of broadly, who's educating right now really well about a biopsychosocial perspective, we have to first give nod to the NOI group, right?
Yes.
The Neuroorthopedic Institute out of Australia, and of course they're international at this point, have really been the leaders in this area. Sometimes with the NOI group's courses, it's certainly they're not pelvic health specific. So I've had to really sort of do some implementation there. But sometimes as well, they've been quite theoretical, right? Almost this new science, cutting edge, but how do I really put that into my clinical practice? And I think they're starting to do that better at this point, which I think is great. At Reframe Rehab, the reason I started this company back in 2020, and it's interesting, we started it just before the pandemic, and we were going to be this international leader, online, live courses, continual interaction with the instructors. So once you take a course, we have office hours every month where, you can come and ask more questions and learn more. And so you're not just, here's a course, away you go.
Yep.
We were going to do this as yeah, that's right. You will see me Sunday night. So the first Sunday of every month, I have office hours for anybody who's taken my class.
By the way, I just want to articulate that is a rarity for you to be able to take a course and then attend free mentorship office hours every month is mind-blowing to us as physios who spend so much money on mentorship and courses. So thank you for that, Carolyn. Thank you.
You're welcome. And it really comes out of a passion. So I'm in the twilight years of my career. I maybe have 7 or 8 years. I haven't decided how long I'm going to work yet, but, I'm staring 60 down the barrel. So, in the twilight of my career, my passion really is to continue to bring the different segments that I've practiced in. So I'm a strong orthopedic MSK clinician. I'm a strong pelvic health clinician. And at this point, I'm a strong pain science clinician. And when we talk about the whole person, we cannot treat the people in front of us with back pain, with pelvic pain, without understanding all of those components. So it's really about kind of bringing that together. So at Reframe Rehab, we only host courses. They're all online. Of course, we were going to do this uniquely in March of 2020, and then April of 2020, every course went live online and it was no longer a unique platform, but that's okay. But our mandate really is to bring that biopsychosocial perspective into every one of our courses and to really break down those barriers. So we welcome MSK clinicians, we welcome pelvic health clinicians, we welcome pain science clinicians. And what you're going to learn on our courses is how to integrate those 3 areas with your patient in front of you. So that's Reframe Rehab.
I highly recommend Reframe Rehab and courses with Carolyn. She has completely changed my practice. So for all of you listening out there who want to get started, just start. They're not very expensive and you will literally hang on to every one of Carolyn's words. Go ahead, Carolyn.
So the other thing that we did in the fall of just last year is as I was kind of watching the development of clinicians and we're struggling as a profession. This is not an easy transition to make. And I acknowledge that. And for me, I've been on this pelvic health journey for 22 years, my pain science journey for about 13 or 14 years at this point. And we are so enmeshed in a biomechanical sort of model that this is a really tough transition. So one of the struggles I think that was evident to me was that people would take maybe one course in using a biopsychosocial approach, but they would fall back on the biomechanical pieces. And so it was very hard to make, really good gains in the skill set that was required. So in the fall, we put a series of 6 courses together on Embodia. So they're all courses that have been taught on Reframe Rehab's platform. And there's my framework courses on there. And then there's a pain science course by Neil Pearson, who's an excellent educator. There is a sleep course by Debbie Patterson. Of course, I've already talked about her. She was one of my mentors in the pain science world. There's a lifestyle course by Dr. Sinead Dufour, who's also a leader in lifestyle medicine for pelvic or for physios and in pelvic girdle pain. We have an occupational therapist, Lara DeRoche, teaching a course on cognitive behavioral therapy, acceptance and commitment therapy, and motivational interviewing for physiotherapists, for rehab clinicians. And then lastly, there's a course on really how do you screen the lumbar spine mechanically, because there's so much of what happens in pelvic health that needs to at least be screened mechanically. And I take a very MDT approach. That's my background from an orthopedic perspective. I've taken lots of manual therapy courses, but I fall back on the framework of MDT. And I do a lot of kind of teaching in that framework as well. So that course altogether bundled 6 courses. If you took them individually, you would have paid $1,800. We've got them on Embodia for $699 because
that's amazing.
the idea is that you really need to take all 6 courses within about a year if you're going to make this meaningful shift in your practice.
Yeah, absolutely.
Otherwise, you do drips and drabs, and it's really hard. It's really hard.
Yeah, and Embody in general is a fantastic platform. I use it to send my clients all their home exercise programs, all of your wonderful, your practices that you've developed. It's a really great platform. I highly recommend it. Carolyn, what are your takeaways for our listeners, clinicians, and clients?
So if you're a patient listening to this, if you're a client listening to this, first of all, when the central nervous system is involved, I want you to remember that you should hold on to hope, because our central nervous systems are highly adaptive, and your nervous system adapted to create more protection, and therefore you have more pain. But your nervous system can also relearn how to be less protective. And if you've never watched Tame the Beast, go to tamethebeast.org. It's a little 5-minute pain education bit that Lorimer Moseley put out. And that should be the start of your journey. So that's the first thing. The second thing is, if you're a client or a patient, I want you to be really critical of the clinicians that you are engaging with and ask good questions, right? And you are the CEO of your nervous system. That means you're in charge of what happens to you. And start asking questions around, do you take a biopsychosocial approach? What does that mean? Are you using questionnaires to assess my sensitivity and what's going on with my nervous system? And if you start to ask those questions, clinicians are going to start paying attention, because what clinicians say to me when we do a lot of talking and dialogue around why it's so hard to change, clinicians say to me, but you don't understand, Carolyn. My patients want me to do something to them. That's what they want. And then I would have to counter that and say, but you don't understand. I have been in that business, in that practice of doing things to patients for decades. I'm a certified acupuncturist. I used acupuncture for about 15 years, from early 2000 to 2015. In Canada, we have to roster to do acupuncture and pelvic health. I actually gave up my rostering for acupuncture last year because I no longer use it. And the reason I don't use it is because it disempowers people, not because it's a bad tool, but because it actually disempowers people. I want to engage people in change that they can make to their nervous system. I don't have to fix them. So as a clinician, I want you to really maybe just hold up a mirror and look critically at your practice and really ask yourself, am I staying up with the evidence? It's hard. It's a shift, and it's not an easy shift, but let me tell you, it is the most rewarding shift that you will make in your practice, because Susan's passion, and Susan's been kind of at this shift about 2 years now, I would say, right?
Yes.
And Susan's passion is exactly what I see in clinicians when they embrace this approach, because you know what? It takes the pressure off us as clinicians to fix people.
Right.
They're not broken.
Yeah.
Can we just get that through? They are not broken. They're sensitive. They're guarded. They're protected. And if we can figure out what those layers of protection are all about, and we can help them figure that out, the powerful changes are incredible.
Yes. And what I would add to that only is that when physios say my clients want me to put my hands on them, I would say your clients want to get better. That's what they want. And if you give them the most optimal way, then they will follow your lead. Carolyn, I have 2 more questions. Okay. These are quick questions. The first one is, you are in practice with your daughter. How in the world did you do that? I have 2 girls and 2 boys, and I am begging them to come to work with me and go into physical therapy. And they're like, nope. How did you do that?
How did I do that? I didn't do it. So, I guess I was a role model, and certainly I have a very close relationship with my daughter, and she's a wonderful, wonderful human being. But really what brought her along this journey, she was accepted into medical school in Ireland. And a month after she was accepted into medical school, my husband was diagnosed with multiple myeloma. And she made the decision that she could not be in another continent when he was going through treatment and through this journey. And he did chemo, he did stem cell transplant, he did all of that piece. there's a 3 to 5 year life expectancy for multiple myeloma. It's one of those diagnoses that isn't great. And we are now 10 years out, and
Wow.
I absolutely credit, first of all, my daughter and my children's dedication to kind of circling the wagons and sort of surrounding him with love. But also the biopsychosocial approach. He completely changed his lifestyle. He meditates regularly. He's always exercised, but he worked on some trauma that happened in childhood that he had stuffed down kind of through this process. He became vegan. I mean, he's done all the pieces, and he is in complete remission from multiple myeloma.
Thank you so much for sharing that. That is a really powerful story. I wasn't expecting that. I was expecting you to say you like forced her, or but thank you for sharing that. We have one more very special thing in common, Carolyn. We're both grandmas.
Yes, we are.
My last question is, isn't being a grandma the dessert of life?
It's
like the dessert of life. Every Tuesday, my daughter lives a mile and a half away. I go to her house and I pick up my granddaughter and bring her over to my house to say my husband works at night. He leaves the house at 7 p.m. and I bring her over before Papa goes to work so that she can give him a kiss. So I read your bio, and you talked about your grandchildren, and I'm like, we have that special bond in common. We're like in the grandma club, and I could not be prouder to be a grandma. Carolyn, can you tell us where our listeners can find you?
Certainly. We have a couple of social media accounts. Certainly you can find us on Facebook. The Facebook group is a closed group, and that's for biopsychosocial therapists. So if you want to join and ask all things biopsychosocial, that's a great place to find us. On Instagram, you can find us at Reframe Rehab. And, as I said, I'm almost 60. Social media is not really my thing, but I love to respond to emails. I'm still that old-fashioned email girl. So my email is carolyn@reframerehab.com, and I welcome questions, discussion, and anything that you have to offer. Say, I'm open to it.
I know that everybody's going to want more of Carolyn, so we are going to include all of Carolyn's links in the show notes. Carolyn, thank you for all that you do for our profession. You truly inspire me, and I thank you for that.
Susan, you are doing a fantastic job in spreading the word, and really just your passion is palpable and catchy. So keep it up. It's wonderful.
Thank you, Carolyn. You're the best. I appreciate you in so many ways. I hope you've enjoyed today's episode of Your Pelvic Health Podcast, where we bring you the real lowdown on pelvic health matters. You can find us on Apple, Spotify, or wherever you enjoy your podcasts. Remember to like, follow, and leave us a 5-star review. It really helps us to bring you more of what you want to hear. And always keep in mind that you need to be your own best advocate, and that pelvic healing requires a whole body approach.